proteinuria, but also think of it as progression from no renal failure to renal failure, and look at these two outcomes separately. And this is what we had in mind when we basically went ahead with our study. We evaluated the plasma levels at baseline of 28 markers, which had been chosen mostly because there were published studies indicating that these markers would have a connection with the complications of diabetes. And we did this in 356 of our cohort and looked at the relationship of those markers at baseline to the incidence of overt proteinuria, which we define as progression from zero or microalbuminuria to overt. And second outcome was renal failure, which we defined as progression from an estimated GFR greater or equal to 60 to progression to an eGFR less than 60, or the patient having had a kidney transplant or dialysis at the follow-up examination. We measured 10 cytokines, 3 growth factors, 4 soluble adhesion molecules, and 11 chemokines. So again, a multiple approach here, just to be sure that we were looking at as many possible markers. But as usual, there is always an additional which may come up later that we may not have considered. The technique was a multiplex bead analysis system, and the person who was in charge of the measurement was masked to the clinical data. Univariate and multivariate logistic regression were done, adjusting for all these factors: baseline age diagnosis of diabetes, body mass index, glycated hemoglobin, hypertension, cardiovascular disease, whether stroke, heart attack, or lower extremity amputation, cholesterol levels, AER, eGFR, statin and ACE medication use, and smoking. So for the first outcome, in the univariate analysis, when we look at the 28 markers, only one was significantly associated with the progression to overt proteinuria. And as you can see, patients who were in the upper quartile of this marker were about 3 to 4 times more likely to progress to overt proteinuria. We subsequently included this marker in a first step in the multiple regression analysis, and as you can see, it remains and included after that all these confounders I listed before. And as you can see, this remains significant, was even more significant than before. So telling us that SICAM by itself, independently of AER, and this is mean arterial blood pressure, has an effect and is a predictor of progression to overt proteinuria. Hypertension is a very strong factor in our cohort, as we've seen in other studies. AER and mean arterial blood pressure are also independent. So these three, and note that all the other factors, particularly glycated hemoglobin, did not play any role in this, and only those factors remain significant. And this is showing you the frequency of the progression to overt proteinuria in the patients with the lowest quartile of SICAM, intercellular adhesion molecule, versus the people who were in the upper quartile, 30%. Our second outcome was progression to renal failure. And as you can see from this slide, immediately there are a lot more of the markers which are related to this outcome. Not only the soluble adhesion molecule, the intercellular adhesion molecule 1, but also the vascular cellular adhesion molecule 1. And in addition to that, there are 3 chemokines, EOTAXIN, interleukin 8, and monocyte chemoattractant protein 1. And 1 cytokine, tumor nuclear factor alpha, necrosis factor alpha. So immediately we can see there is a lot more markers which seem to be associated with this outcome, and some of them are very strongly associated. It's not surprising that when we now do the multiple regression, as I said before, first entering in step 1, all the 6 markers which were significant on univariate analysis, and only EOTAXIN is significant. And the people in the upper quartile of this marker at baseline are up to 7 times and more likely to develop renal failure at the 6-year follow-up. Now, this slide is also telling us something else. It's telling us that EOTAXIN is independent of glycemic control, because glycemic control itself is an independent predictor. So that means that it acts in such a pathway which, based on this analysis, does not go through glycemic control. And then the other interesting finding is that albumin excretion rate and glomerular filtration rate are also 2 independent factors for progression to renal failure, suggesting that both of them should really be evaluated if we want to predict who is going to develop renal failure in this particular group. So of those factors, EOTAXIN is the only one out of all the ones which were significant on univariate, which remain significant. And what it means, it's most likely most representative of all the group, and may have is likely to have in common certain number of properties. And we'll go back to that later. And this is showing the incidence of renal failure, 2.8% in the patients with in the lowest quartile of EOTAXIN, compared with the people in the upper quartile, where the incidence is about 15%. So in this cohort, we have evidence that 2 different markers are independently associated with progression to the outcomes. And SICAM1, an adhesion molecule, is an independent predictor of the progression to overt proteinuria, and EOTAXIN, co-varying with other factors, is an independent predictor of progression to renal failure. Now, there is a fair amount of evidence coming from experimental and clinical data to show the association between adhesion molecules and progression of renal disease. In the experiment published by Sugimoto and collaborators, there was upregulation of ICAM1 with significant macrophage infiltration in the glomerulus of the diabetic animal shortly after induction of diabetes. What is interesting is that when ICAM antibodies were given to the animal, the macrophage infiltration in the glomerulus was prevented, showing that this macrophage infiltration is ICAM driven. And insulin treatment decreases ICAM expression and macrophage infiltration in these animals. Furthermore, if the diabetic mice is made deficient in ICAM1, then all what we expect for associated with renal disease is diminished. Less albuminuria, less glomerular hypertrophy, less mesangial matrix expansion, less expression of TGF-beta and type 4 collagen in the glomerulus, and less interstitial fibrosis, which I think is pretty convincing in the experimental data that ICAM is involved. The clinical data is a little bit, is probably more limited. In this cross-sectional study of Clausen and collaborators, ICAM plasma level increase with in patients who had a proteinuria compared with normal subjects or patients who had no proteinuria. And furthermore, the plasma levels were higher in people who had more severe proteinuria. But this is a cross-sectional study. Insulin treatment has been shown to also reduce ICAM urinary excretion. There are two, as far as I can gather from the literature, there are two longitudinal studies which are in support of the role of adhesion molecules and progression of renal disease. The study of person and Renal was done in type 2, and patients who went from plasma levels of ICAM and other adhesion molecules, which included actually selectin, were elevated in patients who progressed from microalbuminuria to overt proteinuria. The other evidence comes from the diabetes control and complication study, which showed that in patients who had no proteinuria at baseline and developed it over time, the inflammatory score, which included ICAM, was elevated in those patients. And actually, in that study, there were also evidence that tumor necrosis factor receptors were also elevated in the blood. So there is a certain amount of data, then, experimental and clinical, to support our findings. And let's try to understand it in relation to what ICAM does. ICAM is expressed on endothelial cells and also on resident renal cells. Once activated, it will lead to a firm adhesion of white blood cells to the endothelium and its transmigration and infiltration in the subendothelial tissue or interstitial tissue. So one can make a case that ICAM-dependent macrophage infiltration from that point on will be responsible for, as we know it from macrophages, release of cytokine, pro-inflammatory cytokines, which will amplify the inflammatory inflammation in the kidney, but also will be responsible for promoting fibrotic scarring and cellular death. So this is a scheme that we could propose in relation to the role of ICAM. When it comes to EOTAXIN, any evidence in the literature between EOTAXIN and renal disease is rather scant, I have to say. So there are only there's only some evidence that EOTAXIN could be involved indeed in renal failure. In uncomplicated type 1 diabetes, experiences of clamped hyperglycemia will result in an increased urinary excretion of EOTAXIN and other markers. And the same thing happens in another situation which is relevant to diabetic renal disease. Renal hyperfiltration under euglycemic conditions will also lead to an increased urinary excretion of EOTAXIN. Finally, there is a study, this time in type 2 diabetic patients who had increase, who had microalbuminuria and compared with those who had none, showed an increased urinary excretion of eotaxin. So this is pretty much what the evidence is in relation to eotaxin. Eotaxin is an eosinophilic chemokine, so it will uniquely lead to attract eosinophiles. We know that it's expressed, it's one of the organs where it's expressed in the kidney. It's not clear exactly where eotaxin is, in which cell it is expressed. More interestingly, I think, is that it has angiogenic properties through its receptors, and it also can upregulate VEGF. So in that sense, it could be a source of interstitial fibrosis or glomerulosclerosis. And furthermore, it has been suggested that it is atherogenic by recruiting mast cells to the intima of vessels. So this taken as a whole make it a possible candidate indeed to more interstitial fibrosis in the kidney and leading to renal failure. Let's not forget that in our study, eotaxin was only one out of many of the other markers that we found significantly associated, at least on the univariate analysis. That included the soluble adhesion molecules, but also two other chemokines, IL-8 and MCP1, and the tumor necrosis factor. So I have tried to see whether by looking at those, we can make a better case for the role of eotaxin and our findings. And indeed, there are two studies, which are longitudinal studies coming from the Joslin clinic, which are supportive in some ways that these other markers that we found significant on univariate may also be involved. The first study was published by Wolko in 2008, and it showed that increased urinary concentration of MCP1 and IL-8, two that we have in our study, as well as interferon gamma protein 1, protein 10, in patients who were microalbuminuric at baseline and had normal glomerular filtration rate, was associated over time with a decline in renal function. I should say that this was in the urine, but they didn't find any correlation between the urine levels and the serum levels. So that's somewhat negative in that respect. The second study was published by Goda in 2012 and showed that elevated plasma levels, not of TNF, total TNF as we looked at, but TNF receptors, 1 and particularly 2, in patients who were non-proteinuric and had a normal GFR at baseline, were independently associated with the incidence of chronic kidney disease stage 3 or greater. So these two studies, which were seem to sort of suggest that our finding with regards to MCP1, IL-8, and TNF-alpha can also be in another study replicated. I should say that these were a cohort which were most likely to be mostly white. So putting all of this somewhat together as best as we can with the knowledge that we have, MCP1, IL-8, and TNF-alpha, like eotaxin, are chemotatic for various and basically a lot of inflammatory markers. In addition, they share angiogenic properties. Eotaxin and MCP1 are direct angiogenic. And then TNF-alpha is a very pleiotropic marker, which had numerous effects and properties, and which we are somewhat relevant to renal disease, in the sense that it affects blood flow and may have an effect on the hemodynamic factors in the kidney, but it also has a cytotoxic effect, and it upregulates various growth factors, and it happens to also upregulate eotaxin. In the diabetic animal, as you can see, TNF-alpha and MCP1 are mostly expressed in the tubule here, and therefore we want to be sure that, and this is consistent, of course, with what we think is happening in renal failure. So I think we have somewhat a case that eotaxin in covariation with those other factors may have an effect on interstitial fibrosis, tubular injury, and renal failure. In summary, we have shown in this group of patients that two different markers of inflammation and endothelial dysfunction are related to the progression to overt proteinuria and renal failure. Whether to say that the story of inflammation and renal disease is totally unfolded, I think is unsure. I think there is still a lot more to do. But it's certainly what we have to answer also is what may activate inflammation in these patients, because this does not seem, according to our data, being related to hyperglycemia per se. Thank you.
Thank you, Dr. Roy. In the interest of time, we're going to save the questions for later on. The next speaker is Dr. Susan Sumner, whom I've been collaborating with over the past 3 years. Dr. Sumner is the Director of Systems and Translational Sciences program at the Discovery Sciences Division at Renal RTI. It's not Renal, it's Research Triangle Institute. I'm so much nephrologist. Where she oversees the proteomics and metabolomics core. In September 2012, Dr. Sumner and her team established the NIH Eastern's Regional Comprehensive Metabolomics Resource Core as a part of $9.3 million grant from the NIH Common Fund. Dr. Sumner serves on the editorial boards of Metabolomics, Journal of Applied Toxicology, Journal of Toxicology, and RTI Press, and is adjunct faculty of, I believe, at the Brody School of Medicine at East Carolina, and the Department of Nutrition at the University of North Carolina, Chapel Hill. She's a superb individual, very helpful, and really I invite you all to collaborate with her if needed. She has supported us through thick and thin. Dr. Sumner.
Okay, thank you for the invitation to come and speak, and I hope we're always looking for collaborations. I'll give the disclaimer that I'm not a nephrologist, I'm not a medical doctor, so if I use some terms wrong, please be patient with that. But I am a spectroscopist, and we know how to measure molecules and things, so we'll tell you about what we've been measuring and who we've been collaborating with, and why, and maybe that will interest you in working with our team also. So do I bring the slides up, or it's 3? That's it. Thank you. Okay. All right. Almost there. Here we are. Okay, so we'll move forward. So I direct this center, but I wanted to tell you that RTI, in case you haven't heard of it, we're a nonprofit basic research institute. There's about 4,000 employees. About half of those are in the Research Triangle Park where I'm located. And so I wanted to let you know not to be afraid to collaborate with us, because we are just sort of a nonprofit institute. And we generate all of our funding through grants with the government, just like universities. It's just we spend all our time doing research and not necessarily teaching, unless we do that with the adjunct positions. Some of you may have heard of RTI, and relevant to this crowd, something that RTI has done that you've probably heard of is the discovery of Taxol and camptothecin, which are the #1 and 2 world-leading cancer therapeutics. And Dr. Wani, who actually discovered Taxol, is still at RTI as an emeritus scientist. It's a real pleasure to get to know him. Okay, but I'm here to tell you about metabolomics. And so has everybody here heard of metabolomics? So I have an idea of anybody. Hands up if you've heard of metabolomics. So there's not a lot of hands up. So I will tell you a little bit about it. So it's kind of like thinking about genomics or proteomics, but we're looking at what's going on downfield of the protein, and it's the low molecular weight complement of cells, tissues, and biological fluids that we're examining. And in metabolomics, you have the opportunity to basically profile the biochemistry of an individual or a system apart from or in addition to your genome and your proteome. And metabolomics, and there's another term, metabonomics, that you may hear, what it's used is to determine the pattern of changes arising from disease, dysfunction, disorder, et cetera. And most of our studies are conducted like cases and controls kind of studies, and we're looking for lots of signals to be able to distinguish those cases and controls. So that's what I'll be showing some examples of. So with this crowd, I don't think I need to be trying to be convincing that we have to look at something other than genes based on the 2 prior talks. And in some presentations, and especially early on and when we were doing metabolomics, a lot of people would say, well, why don't you just do genomics? But no, we're beyond that now, that we understand that there's post-translational modifications that occur, and that's what we need to be seeing with these other technologies like metabolomics. So as you know, as MDs, your cells and tissues and fluids are rich in low molecular weight metabolites, and that's what we need for our diagnostics and to be able to gain insights into mechanisms of what's been disrupted at the cellular level. And a lot of the work that we do in my group is focused on using non-invasive biological specimens to be able to define better biomarkers for disease. But we also do a lot of work at the cell and organ level also to develop corollary markers. So Dr. Sagi had mentioned that I run one of the NIH Common Fund metabolomics cores, and there are 6 of them that the NIH Common Fund established over the last couple of years. You see at Michigan, Kentucky, Mayo, Davis, Florida, and at RTI. And any of these cores are open to doing collaborative studies, not just ours. So all of them were funded with the intent to promote clinical and translational research. So none of the cores in themselves have a fundamental basic science research plan that's been funded, but the funding is to get out and work with a lot of people to really start using metabolomics as much as possible to develop new biomarkers and understanding of disease. So because of that, in my group, we were able to develop about 60 collaborations over the past few years to do these pilot studies. And so this has been really useful because we've been able to analyze lots of sample types. You can see kidney, liver, brain, ovary. We've been doing some work with the eye, lung, muscle, and then there's the relatively non-invasive serum, plasma, feces, urine, saliva. So if there's not a biospecimen up there that you're interested in, we could certainly figure out how to analyze it by using the same methods. And that's actually one of the really nice things about metabolomics, is that what we're capturing, this broad spectrum of metabolites, are detected in many of the same biological fluids and tissues, so you can develop corollary markers in your non-invasive fluid for what's going on in the tissue. And you can see we've done a number of investigational areas, and I could talk about any of them, but what I've picked today to describe is some of the pilot studies that we've been doing that were related to diabetes and kidney disease for the most part. As far as translational markers, I did just want to say that what we do in metabolomics, it doesn't require like a special chip for a certain species. So what we're measuring, metabolites are conserved across species. So what we measure in an animal model and in a human subject are very similar analytes. So a lot of interest is in the use of metabolomics in translational work to be able to use these animal models and then translate that to human subjects. And over on the right side of the screen are a lot of the different species or age groups that we have samples derived from. Okay, so for technology, we do, I've referred to broad spectrum profiling of metabolites using nuclear magnetic resonance spectroscopy and time of flight mass spectroscopy, either coupled with a liquid chromatography or gas chromatography. When we're using these methods, we detect thousands of signals. Like we can get 60,000 signals in a spectrum of a UPLC QTOF-MS or a 2D GC-TOF-MS. So the question is, what are all the signals? I'm not going to claim that we know all of them, because we don't, but we know a lot of them. We have these what's called retention time mass libraries that we can match the signals to. So we use a variety of methods because molecules act different with different types of spectroscopy. That's why we have a lot of different kinds. And so we have to use multiple methods to really get a wide coverage of the metabolome. So that's what we're calling, our broad spectrum methods, or when we don't have a hypothesis, right? When we do have a hypothesis for what's going on, we use what's called a targeted method, which most people are more familiar with, where we set up and we analyze for specific analytes in a quantitative manner. And that's typically, historically what people do. So we do both. Okay, and then we've gotten to where we're doing a lot of metals analysis, and more epidemiologists are wanting to know not just one thing to try to correlate with an adverse outcome, but what's a broad spectrum of environmental exposures that you can correlate with adverse health outcomes. So we have more broad spectrum environmental panels, as well as this detection of endogenous compounds. So no matter how we get the signals, the workflow is very similar. We may have, for example, cases and controls, and we use a multivariate analysis, and we look in multivariate space, and we determine where the controls fall, where the cases fall, and then we determine what are the signals that differentiate those cases and controls. We look at our libraries, we figure out what the unknowns are, and then we take those and we map them to biochemical pathways. And our pathway mapping tool that we usually use is called GeneGo. It's not publicly available. It's a commercial product. We think it's the best, but there are publicly available products that can be used also. Okay, so before I give some examples, I know that there's probably already been a lot of concern out there that we're detecting all these signals and we don't know what all they are, and it's not targeted analysis. So how do you know what's random? So it's our concern too. So we have a lot of quality control behind what we do, starting, very early on with calibrations of pipettes and balances. We randomize our samples. We have QC standards that we put within the runs. And then we look at pre and post-run responses. And then we have a lot of quality control steps in our data formatting, alignment, transfer steps, et cetera. And then we have a lot of interactions with people up front, which is really important. Metabolomics isn't a lab course, so it's not insert your sample and get your level of, LDL or whatever you guys are sending out to get measured. So we do a lot of reviewing of the metadata that comes with the sample so that we can really understand what the study phenotype is, okay? And a study phenotype is this person, this is a disease group, this is a low score, this is a high score disease group, this is a healthy group. So we do a lot of reviewing of that metadata and to get really good study designs. So it's all about comparing states of wellness and states of sickness. And I will start off by talking about a study that we've been doing with Snezana Petrovic, who's at Wake Forest University. And what she's looking for is a urinary metabolomics profile of early chronic kidney disease. So I appreciated the talk right before me, definitely. So the sample that we've been using is from the Diabetes Heart Study, which is a genetic and epidemiological study of 1443 European American and African American patients from 564 families. What Snezana's been interested in is how are we going to get biomarkers to diagnose chronic kidney disease and to predict those who will progress to end-stage kidney disease. Hope I say these things right. Okay, so for our pilot study, we took urine samples that were randomly selected from two groups of 50 diabetic controls who didn't have chronic kidney disease, and 50 diabetics who had chronic kidney disease. And the samples were matched for BMI, gender, and age, because we know that metabolomics profiles can differentiate by BMI, gender, and age. So we matched for those. And then you can see the definition. I'm not going to try to explain it of what the controls were and what the cases were. And then it excluded smokers and individuals over 70 for this. And this included stage 2 and stage 3 chronic kidney disease. Okay, so I was talking about we do the pattern recognition approaches, and in this case, I'm showing what's called a principal component analysis of all the subjects that were matched by gender, age, ethnicity, and BMI. And we get this clustering here, which are probably our controls. Yes, it is. And then here are cases. And then we have this one subject up here that must have been chewing a lot of sugarless gum or something. So we were able to take that particular analyte out of the analysis. And I wanted to mention that because if you have any medications you want to see if people have been taking, you want to know if they're taking them, metabolomics can tell you who's being compliant or non-compliant with their medications, as well as measuring the endogenous compounds all at once. So if somebody's drinking alcohol, we could tell you that they were, even if they said no. And we wouldn't have to set up a specific method for that. It would be something that would just show up in our metabolomics analysis. So we removed this erythritol subject, at least those analytes for that subject, and then we did another analysis. We got different separation or a better separation of the groups, and then we removed all the glucose that we measured. And the reason we did that is because you already know that glucose is a factor, right? So we wanted to find what are the other things. And so this is the analysis that we came down to for 77 subjects with the glucose removed from that analysis. Okay, that didn't work. That worked, okay. So if we grouped them by chronic kidney disease with stage 2 and stage 3 together versus the control, we came up with these metabolites listed here as being the metabolites that differentiated the cases and controls. Now at this point I have to sort of apologize because I don't know exactly what all those metabolites mean in chronic kidney disease, but you probably know a lot about that, and if we sat together and worked on the problem about what does it mean in the pathways and relation back to other things that you already know in chronic kidney disease, we might be coming up with a really good panel of markers. But one thing that I do know is metabolomics told us some of the obvious things, like you would expect creatinine and to elevate, and that did. So it's always nice when we see some of the obvious things. And then there's these other things that are our biomarkers that are exploring. Now, we also looked at the subjects who had diabetes for longer periods of time, and differentiated those by cases and controls also, and came up with some of the same metabolites for the longer illnesses, and then some additional ones that are different. And then we looked at a group with stable or slow decline in eGFR, and compared those with those who were rapid decliners in eGFR, and came up with a different set of metabolites. So that's kind of where we are now. We're working with Snezana to try to make sense out of the data. One of the other things we did is we did a metals profile looking at about 20 metals in the urine samples to see how that was correlated with the chronic kidney disease versus the control. And we found that copper was significantly increased in the chronic kidney disease group. So I didn't know exactly what that meant, but I started looking in the literature and found out that some people with chronic kidney disease are taking copper supplements. So I had wondered if that was what the case is, but you guys might tell me more about that. Okay. So another study that we've been working on is with Pat Brophy and David Ashkenazi, and this involves trying to get a urinary marker profile for acute kidney injury. This involves the collection of urine from preterm neonates, and this is done by putting cotton balls into the diaper, and then the cotton balls, get wet with the urine, and then we take those cotton balls and extract them and do the metabolomics analysis. So what Pat and David have told us is that with their preterm babies, they really need to have a better understanding of which ones are going to develop acute kidney injury, because that could change their course of treatment of the preterm babies early on if they knew who was going to get it and wasn't going to get it. So we started off by looking at cases and controls, because that's always a really good way to start. We looked at preterm babies without acute kidney injury and preterm babies with acute kidney injury, and we could very easily derive a set of metabolites that defined the state of acute kidney injury in these preterm babies. In addition to that, we've been looking at the kidney for different age groups of preterm delivery. So this is gestational age was less than 27 weeks, 27 to 28 weeks, or greater than 28 weeks. And in babies with normal kidneys, we can see, it looks like we're seeing a development pattern of the kidney, which is good. And it's sort of interesting, because I don't think it's just by happenstance that we can see that, because in the acute kidney injury neonates, the ones that are 27 to 28 weeks old, we see here, but as we would expect to start seeing a pattern in development, it's all overlapping. And so we thought that that may be important for getting that predictive biomarker in development of kidney injury. Okay. And then If we were comparing just those at less than 27 weeks between the control and the AKI, looking at what the biomarkers are for that, and mapped those onto pathways and found that the RNA biosynthesis pathway and galactose metabolism is very important for this staging this acute kidney injury. And this is consistent with work that was published in 2013 using a rat model for acute kidney injury that also showed this pathway is important in the development of acute kidney injury. And then we looked at the different age groups, and as they're aging, we still see this pathway as being important, but then we see other pathways as increasing in differences between the control versus AKI for those age groups that we're looking at. So lastly, I just wanted to mention that when we're comparing these groups, one of the other things that we found is these 4 biomarkers, hydroxybutyrate, ethylene glycol, glucuronate, and N-acetyltyrosine, as being very important in differentiating the AKI by age groups. Now, you probably just ask yourself, what's ethylene glycol doing in there? Because that's not a good thing, and these are preterm babies, and they're really small, so the amount of ethylene glycol might be big, you know, if you think about it that way. We don't know, but we know it's ethylene glycol, and it might be coming from the feeding tubes or something that's used in the formulation of, you know, getting the feed in there. So, because of the PEG that's used in all the plastics. So that's kind of where we think it's coming from. The other thing that we saw was this 2-hydroxybutyrate, which we see a lot of times in kidney studies is increased in kidney injury. But there was a really interesting study recently that was published in 2014 that showed that hydroxybutyrate is protective against paraquat-induced toxicity in the rat. And in this study, they're suggesting that the reason that you have increases in hydroxybutyrate may be because of resiliency or protection against injury, and that it's a mechanism to show that they're kicking in to protect rather than a biomarker of the adverse response. Is a biomarker of a response. And then there were a number of other biomarkers, like the tyrosine pathway has been implicated in AKI. We saw that, and also in our metabolomics analysis. So one of the things we do try to do is go into the literature and find out how our results compare to what's already known, and then what else do we see besides those. And then the other things that we see become a real focus of trying to find the new markers. Okay. So metabolomics is sort of the cases and control kind of study. We've also been working in predicting response to treatment kind of investigations. And then we've been doing a number of studies also that I don't know if I have any slides on with me, but doing lead optimization and preclinical animal studies, target identification, lead optimization kind of work. But I'll show you this study, which is a response to treatment kind of investigation. This is some work we're doing with David Collier at East Carolina University. His interest is to understand more about why and how some adolescents lose weight when they're in healthy lifestyle programs and other adolescents don't. So the adolescents that he works with have extreme BMIs. And in this particular study that I'm going to show the results for, I think everybody had a BMI over 60. And about half the adolescents who enter their healthy lifestyle camp lose weight, and the other half don't. And the half that don't lose weight are sort of demoralized by that process. So what they really want to try to do is to get a biomarker that could help them understand which adolescents do we want to come to our camp, because they have the most promise of losing weight, and they won't walk away feeling, having a lower self-esteem. So that's what sort of drove this whole process. And they had been using psychosocial inventories to try to do this prediction, and those weren't working. So we were trying to find what else could we do. So we did this metabolomic study, and I'll give you the end answer, is that we found that branched-chain amino acids were elevated in the urine of the adolescents that did not lose weight during the healthy lifestyle program. So at that time, I had no idea what that meant. I'm a physical chemist, remember? So it's like, why are the branched-chain amino acids elevated? We tried to get it published, and everybody was kind of going, we don't know what this means, and nobody's ever done this before, so, that means you're wrong. Then all of a sudden, I don't know if you're familiar with the branched-chain amino acid story, for example, that came out of Harvard, where they showed that if they were looking at an adult population at baseline, this was from the Framingham study, that they took samples from subjects that were healthy, and they had one cohort that developed diabetes later and another cohort that didn't develop diabetes later. And they found that they had higher levels of branched-chain amino acids in the cohort that went on to develop diabetes later in life. So we were like, yay, now we're beginning to understand what this means, that the reason, the branched-chain amino acid story with our adolescents is that the ones have higher levels that aren't losing weight, and that could be the group of adolescents who are going to go on to develop diabetes later in life. So the whole, story about branched-chain amino acids and the mechanism behind that is something that's really being exploited by Chris Newgard's group that's at Duke and Chuck Baran's group at University of Michigan, and they're making a lot of progress in understanding the mechanisms behind that. And I know that Chuck just published a paper in Cell recently on that, but that was a good discovery study in hindsight, and we did eventually get it published, but early on, I think a lot of the metabolomics work was a little bit harder to get published because we didn't know exactly what that meant. So we've been working with Dr. Sagi in the area of probiotics and kidney disease, and this was sort of a challenging study because, based on the number of samples we had and the fact that it was divided over, these demographics and over, a wide age range and 2 genders, and all of these things already cause differences in metabolomics profiles. So we knew this was going to be really challenging. But in this study, what we wanted to do was try to understand how the probiotics that the patients were taking who have chronic kidney disease, how that was correlated with a relevant clinical response. So Dr. Sagi shared all the clinical data with us, and our statistician, Susan McRitchie, found that there was a significant decrease in BUN in some of the patients who were on probiotics for 4 months, and then the BUN either remained the same or elevated in the other patients who were on the probiotics. So that was our clinical measurement that we could get out of all the metadata that was provided. So it seemed like if you're making that measurement in the clinic, you must think it's important, so we wanted to see how the metabolomics profiles correlate with that, and we could get a very good distinction between those who had a decrease in the BUN or an increase in the BUN. And now we're leaving it up to Dr. Sagi and his team to help us understand exactly, we're putting this on pathways for the group, so we will take it to pathways, but to understand exactly what this increase or decrease means. And I did just want to mention that I've been showing some of these plots, and they have VIPs. These are variable importance, and the higher the number, the more important that metabolite is to defining the phenotype of interest. And then, of course, we also calculate p-values, and in this study there's a number of p-values less than 0.05. Now, in my world, in the metabolomics world, you do not have to have a p-value less than 0.05 to be important, and the reason is because we're looking at pathways and patterns of changes. So even if there's a p-value of 0.25, if it's important to creating this pattern of differentiation, it still makes it to our list. But because the normal statisticians want the p-values. We also provide that. Okay, so that's kind of where we are on that. I wanted to mention this study. It has to do with breast cancer, but it's just to talk about the fact that we can do cell work and why we would do it. So in this case, Delisha Stewart, who's in my group, is working on developing a method to screen drug candidates for impacting triple-negative breast cancer. So we're trying to identify a target and then to screen drugs. So she's taking cells from patients who have triple-negative breast cancer and cells from patients who have luminal A breast cancer. And we've been able to look at those cell types and see the difference in the metabotypes of the cells, okay? Then we take the cells and treat them with Taxol, which is a cancer chemotherapeutic, and in the presence of cell types, the luminal A cells and the triple-negative breast cancer cells respond differently. Then, in addition, we take the cells and we treat them with compounds like carbon-13 labeled glucose or carbon-13 labeled glutamine, and we look at how the cells utilize different sources of energy, like sugars, or how they utilize different amino acids, and we can see the uptake of those amino acids and the sugars differently. So, I'm not sure exactly in kidney disease what kind of study design would be important, but I think you can see that, if we can differentiate patients based on their response to treatment by using their cells, and we can discriminate the response of the treatments and the utilization of energy sources and amino acids. There's probably some way for us to design a study in kidney disease like that also. Okay, so I'm only going to make a couple more points. One is on measuring biomarkers in general, and tell you we're not stuck on metabolomics. We do proteomics, DNA adducts, protein adducts. We measure, we do PK curves, about anything that would come up. If we haven't measured it, we do when we work with somebody, because that's fun. But one of the things we're really in is trying to link this whole exposure concept to disease. And in kidney disease, I know that there's been a link between exposure to arsenic and the development of diabetes, right? So you've probably read those papers, whether you believe them or not, but Anyway, so we've been working with Rebecca Fry, who's an epidemiologist at UNC Chapel Hill. And she gave us cord blood samples from women who either had a high arsenic exposure or women who had a normal arsenic exposure. And we wanted to see if we could tell the difference in what the metabotype was of the blood available to the fetus based on that arsenic exposure, and we could identify 28 endogenous metabolites that corresponded or that differentiated this high versus normal arsenic exposure. And by putting those onto pathways, we found a number of enzymes related to this arsenic exposure that had some known literature link to non-insulin diabetes. So, and I will say at the time that we started this study, my group didn't know about the arsenic and the association with the diabetes. Our challenge originally was just to differentiate these cord blood samples and get these pathways. So we felt pretty successful. It was a sort of a semi-blinded study in that regard of not knowing the outcome. So we've also, in addition to human subjects, we do a lot of work in animal models, and the study that I've selected to show here is some work that we've done with Martin Blazer, who's at New York University Medical Center, and what we've been doing in this study is looking at samples that he's provided from mice that have been exposed to subtherapeutic doses of antibiotics. And when you compare those subtherapeutic dose mice, which would be these, to the control mice, we find that they have an obesity phenotype. We've been looking at the liver, cecal, and serum from these studies and showing differences, which we aren't surprised by, because if you give a drug to something and not drug and you compare control and treated, you're going to see differences in their metabolome. So we're very familiar with that. But what Martin did also was take the feces from these control mice and subtherapeutic dose treated mice and put those in a germ-free mouse model, and was able to, and then we were able to also show that we could see differences in their serum and liver and fecal matter depending on what fecal transplant was used. And this Martin's group at New York University Medical Center has done all the microbiome analysis, and what we've done is been able to correlate what the metabolite changes are that we see with what the microbiome changes are that he saw. And these papers are in submission right now that show these correlations. But one of the points I wanted to make here is that to do this work, we developed a microbial panel of metabolites that we can detect as a targeted list of metabolites. And I thought that that may be really important in the area of kidney disease, to be able to understand the effect of the microbiome and the metabolome between patients that maybe are responders or non-responders, or progressors or non-progressors. And so we've also, Martin wrote this book on the missing microbes. You might have seen that. It gained a lot of publicity the last year or so. And then we've also been using a similar approach, working with him, looking at antibiotic-mediated gut microbiome perturbation and how that accelerates type 1 diabetes in a similar mouse model study. But this particular one is using a pulsed antibiotic treatment. And at a little higher dose. But they also show in this that there is the type 1 diabetes associated with the antibiotic treatment. And then they've looked at the microbiome, we've looked at the metabolome, and been able to correlate specific metabolites with their microbiome changes and the association with diabetes. So I think I'll end there and just say that, we have a group of excellent analysts that are really interested in working with people, and how our core works is when somebody comes with a study, we usually ask one of our team members, are they interested in that, match up an analyst and start reviewing metadata and trying to get a really good study design. Okay, and I'm going to add one more thing. In addition to doing the biomarkers analysis, I did want to mention that last year, or maybe it was 2 years ago now, we did get a grant with Bill Schmoyer, who you may know. He's at Nationwide Children's Hospital, and his expertise is in glomerular kidney disease. He's a pediatrician. And in this particular case, what we're working on with Bill is to develop a biorepository to do metabolomics analysis to get biomarkers for glomerular kidney disease. So if anybody's interested in that kind of work, we're definitely willing to help try to establish these biorepositories as well as do analysis. Okay, thank you.
Thank you, Dr. Sumner. Wow, so much to learn. The next speaker is Dr. Nathan Wolf-Levine. It's really a pleasure to have him here. I know we're running short of time, and his bio runs into pages and pages. He's a graduate of University of Witwatersrand, Johannesburg, South Africa, and Dr. Levine is currently clinical professor of medicine at the Icahn School of Medicine at Mount Sinai Health System, and was a co-founder in 1997 and past medical and research director of the Renal Research Institute, New York. He has made leadership contributions to the development of DOQI, which people know, Dialysis Outcomes Quality Improvement, and KDOQI and KDIGO practice guideline organizations. He was a principal investigator in the HEMO and the FHN NIH dialysis trials. Dr. Levine was vice president of the Association of the Advancement of Medical Instrumentation, president of the Renal Physician Association, and I can go on and on and on. And I want to learn from him, we all want to learn from him today, what are the strategies to reduce mortality in ESRD population. Dr. Levine. Thank you.
Thank you very much, Dr. Sagi, for your kind invitation to join this very distinguished program. What I'm going to speak about today is actually a well-trod path, but I will be, I think, adding some elements that are new and offer some hope for advances in this field. The hemodialysis, as we know today, is an incomplete therapy in that, in fact, we don't reduce most uremic toxins. That volume overload is really reduced adequately in most of our dialysis treatments, that we don't replace the substances that are synthesized by the kidney adequately, that vascular access is very often inadequate to provide a treatment within the short times that we dialyze patients. Our patients have many symptoms between and during dialysis. There's undoubtedly an extremely high hospitalization and mortality rates, and perhaps from the patient's point of view, they just don't feel well most of the time. So we don't actually do a very good job in dialysis, and we are looking at this project, all of us, this problem, really from the edges, and the fundamental areas are not being looked at because they're so difficult to look at very well. And perhaps if there's time I can enlarge a little bit on that thought, but I want to first show you where we stand here. So here is a return to the past, and this is Abel, who created the first dialyzer, which if you look at it in 1913 looks very much like the hollow fiber dialyzers of today. The big difference is that while the hollow fiber dialyzer today has something like 10 or 12,000 hollow fibers, this just had about 20 or 30. And it's that essential difference that was not recognized for a very long time that made the hollow fiber dialyzer a very efficient dialyzer, which is used, I think, in over 99% of dialysis treatments today. But it's interesting to see, and I thought you might be interested, is what happened when Professor Abel presented an ingenious method of removing substances from the circulating blood, which can hardly fail to be of benefit in the study of the most complex programs. This is in 1913. So Professor Abel has constructed what is practically an artificial kidney. In many instances, the working of the added excretory organ is more rapid than that of the actual kidney of the animal. And what I like is this here. At the close of the demonstration, which excited the liveliest interest and discussion, Professor Abel was accorded round after round of applause. Now, in some 40 or 50 years of attending meetings in this country, particularly the ASN and ASIO, on only one occasion did I see an audience come to its feet and applause a speaker, and that was Belding Scribner when he described the AV shunt, which he and his colleagues in Seattle had invented. So, some determinants of outcomes in hemodialysis. In general, we have a kind of a view, and I have reinforced that in my first slide by saying there's a relationship between dialysis and survival. But I think it's really interesting to look at the demographics briefly and the effects of body size, of race, ethnicity, and the other factors as well. There's no time to go into them today, except perhaps the one about duration of dialysis, which largely for reasons of convenience and for commerce is shorter than it should be. I don't think in the average time in this country for dialysis, which is somewhere between now 3.5 and 4 hours, depending on where and how you dialyze, that it's enough time to remove the water, the salt, and the uremic toxins. And you'll see at the end of this talk where this becomes actually quite relevant. And volume overload is certainly one of the issues. So let me just go through these small points which may be well known to you, but I think they're interesting. So the first is when you look at all-cause mortality by race in the United States, for a Cox survival model with 1 year follow-up and adjusted for age, of course, for gender and diabetes, you see there are substantial differences between whites, blacks, and Asians. And I should say that the Asians represented here that are influenced this much better survival are Southeastern Asians, not the South Asians, Indians, Pakistanis, Bangladeshis, but the Chinese, the Japanese, the Koreans, and so on. These are the people that are contributing to this markedly reduced mortality in patients. And there are differences also in ethnicity effects between Hispanic whites and Hispanic blacks, with Hispanic whites doing better, doing better, yes, than non-Hispanics doing better. Got it the wrong way around. Hispanics doing better than non-Hispanic whites, and blacks doing about the same. So that's race. And then we look at a combination here. This is a remarkable slide. It has so much in it. The bottom figures relate to BMI. The vertical figures relate to mortality rates, and the various colors relate to the dose of dialysis, expressed here as urea reduction ratio. And I won't go into the detail. It's a fascinating slide for me, but it shows in general that the bigger you are, the better the survival, that within each group of dialysis dose, the better the survival, and certainly there's differences between whites and blacks, Hispanics and non-Hispanics, in that the best survivors are the patients who are Hispanic, who are large and have large doses of dialysis. So there's a world here of influence which we can't actually perceive in our patients as we see them, but the differences are really quite marked. This is from the USRD. Yes. And just one other interesting fact in regard to strokes, how different the proportion and type of stroke is, different in the East, in Beijing, Shanghai, compared to the United States, and in this case Austria and the United Kingdom, in that hemorrhagic strokes are far commoner in the East, and ischemic strokes are far commoner in the United States and in Europe and in Austria as part of Europe than they are in the East. So we have big differences in the stroke incidence, which obviously relate to ethnic and possibly genetic differences. And when you see what behind the dialysis mortality, that there's a relationship between atherosclerosis-related deaths and all causes of death, when you look at 26 countries over the world, that the patients who have the lowest cause of death, the lowest death rate, have also the lowest amount of atherosclerosis. That's in the bottom left-hand corner. These represent the countries of the East, to an extent the Middle East, and the ones right at the other end are patients from Eastern Europe. In between there's a big range. So in other words, a lot of our mortality is in fact related to the ethnic propensities for cardiovascular disease of our patients. So I'm going to actually just spend much of the time in this talk on two issues for which we see real improvement. The one is the question of sodium and fluid overload, and the second is this new technique of hemodiafiltration, which is not yet clinically available in the United States, but has recently been approved by the FDA as a technique that will be approved eventually. It's been held back for many years, and I'll come to say something about it a little later. So, most patients with fluid overload, the mean systolic blood pressure is over 150, which takes into account that fraction of patients who have very low blood pressures due to uremic cardiomyopathy. The mean dialysis time in this series is 3 hours and 35 minutes. And there's full recognition by everyone of the importance of salt restriction and volume reduction without actually implementation of the idea. This goes back a long way. You can't read this very well, but this is a worksheet of people working at Lindholm and people who were influenced by Dr. Scribner in 1963, who portray when people are dialyzed weekly or twice weekly, the kind of weight they would put on, dialyzed for 10 hours, full removal of excess fluid. And the importance placed on this by Dr. Scribner is well known, so much so that in a paper in JASON some years ago, actually reprints in the series they had at that time of classic papers, reprints a paper by Scribner on the treatment of chronic uremia by means of intermittent hemodialysis. And this is reviewed by another famous nephrologist closer to our day, Eberhard Ritz. And in this review he says, in this very first article, Scribner immediately grasped the importance of hypovolemia. It is almost amusing to note that very recently, authors still felt it necessary to point to the importance of hypovolemia in the increasingly confused discussion on hypertension and optimal long-term blood pressure management on dialysis. So we keep being reminded all the time, but very little of progress has gone on. The one exception that was known to everyone for at least 20 years was the experience in Tesson in France, where dialysis time was originally 8 to 12 hours, 3 days a week, 12 hours during the day, with a very excellent French chef providing lunch halfway through the day. And that was reduced over some years, many years later, to 5 to 8 hours. All patients were educated to sodium restriction. The dialysate sodium concentration was 135 to 137, and very few patients were on drugs for hypertension. So this shows what the course of the patient would be over a period of months as the blood pressure comes down, and you see the columns are, as the patient's weight goes up, weight not due to salt and water, weight due to fat and protein. And this experience, first by Dr. Laurent and Dr. Charat and others after them, was the standard. But nobody would take it terribly seriously to do in their own clinic for obvious reasons. You had to keep the patient there much longer than was possible. So it was a model, but not one that was practically valuable. Then came Dr. Dorot Mies from the Netherlands, who fought with all the nephrologists in the Netherlands at that time. And he visited Turkey, and I'll show you what the significance of that was in a moment. He visited Turkey, and he impressed the Turks with what he thought was important, which was that there should be 12 to 15 hours of dialysis a week, not excessive, much less than Tesson, that the dialysate sodium concentration would be low, that antihypertensive drugs were not necessary in most patients, that there should be strict dietary salt restriction to reduce interdialytic weight gain below 2 kilograms, and that patients should never be told, don't drink, because really drinking is not under a patient's control. If you're thirsty, you drink. They must be told that the sodium intake should be reduced so they won't feel thirsty, so that they won't drink. So the group in Turkey that he influenced were in Izmir, and to this day that group has been the only large group that I know of in the world that have actually achieved the same results as Tesson virtually, that 90% of their patients are normotensive on dialysis, and 90% approximately do not require antihypertensive drugs. 4% only require drugs in this. And these things have been well published in our best journals. No patient with edema and heart failure decrease in intradialytic hypertension and cramps. Why? Because there's less weight to remove, and increases in hemoglobin and serum albumin levels, and a very low rate of mortality. But again, the Turks falling into the group that has a low mortality anyway, one can't really interpret that possibly, but if I tell you, compared to our approximately 20% in this country, their average mortality age matched is about 12%, you see that there's really a very big difference. So the treatment of salt restriction in the treatment of end-stage disease was one of the things that they showed very, very clearly. And you can see by comparing Center A with Center B that although the blood pressures were more or less the same, the interdialytic weight gain was a full kilogram difference between the two. And the number of people who had systolic pressures above 140 was twice as many in those that were not salt restricted in Center B. And obviously, as I said earlier, the intradialytic hypertension was also more than 2 times less in the ones Center A who had sodium restriction. No question about the benefit. I'm trying to convince you that this is all well known. Everybody knows it. Everyone's taught it, but it doesn't happen. One of the most interesting findings, because we have on dialysis those patients with low blood pressures who have a high mortality and a very high hospitalization rate. Those are patients who were hypertensive years before, have gradually lost the function of their left ventricle and in the right ventricle. And these patients are very miserable, do very badly. Well, what was shown here, that if you look at the patients on the right side, who had a reduction of extracellular fluid with slow ultrafiltration over time, because their blood pressures are so low you just can't treat these people for short periods of time, you see that the ejection fraction increased. And this is a very, very interesting finding, because it actually literally gives new life to these patients. And then the regression of left ventricular hypertrophy, 2 echocardiographies in 15 prevalent HD patients with a mean interval of 37 months. And you see that as the blood pressure came down, both systolic and diastolic, the thoracic index were reduced, the left atrial diameter decreased, but most important, the left ventricular mass index increase was substantial. In the daily dialysis study, which was completed some years ago, which is still being studied, there was a difference in left ventricular mass size with daily dialysis. It was not to the extent of this. Because there was no, when I say because, perhaps that's going a bit far, there was no attempt to restrict sodium in those patients. And a more thorough discussion of this very important issue, because left ventricular mass and survival are very closely linked. When we looked at a summary of some of these findings from the Turkish group, these are over many years of work, at least 6 years of work, they all show the same reduction in left ventricular mass. I don't think we have time to go into the detail of that, but you know, I'm sure you understand that there was a reduction in left ventricular mass. Now, just a personal word here. I was very fascinated by the studies being done in Turkey, and I went there a couple of times. The first time I just saw the results, came back, and then when I tried to tell my colleagues how to do it or what we should do, I really couldn't reproduce the information. So somewhat shamefacedly, I went back again, stayed 2 weeks, and followed Dr. Ercan Ok, who's the leader and has been for some years, as to exactly what he does. And I'll tell you in a few minutes. It is so simple, but difficult to do in our current environment in the United States. So here we have some of the results, perhaps not very clearly visible, that our patients who were hypertensive became less hypertensive over time, and the differences of around 15, 17 millimeters of mercury of systolic blood pressure, something you never see as an average in patients who are receiving antihypertensive drugs. This is far in excess of that kind of result. And then the ones who had low blood pressures, they stayed the same or they increased, as I showed you before. And this is the kind of thing with one of the dialysis units. This is how the blood pressure fell over a 2-month period. Some fell much more than others, but in general, there was a substantial reduction in blood pressure in those patients who were treated with this approach. I should, and we have a forthcoming poster at the European Dialysis and Transplant Association, which shows what happens to the blood pressure and other details. anyone's interested in this, please give me a call. So all right. So I've told you all this, and now it's sort of like child's play, simple menu to do what you actually need to do. And I don't know what's done in the units here with Dr. Saji and his colleagues, but in the places where I have been working for the last 25 years, there's such a thing as the estimated dry weight. And that's the weight that the patient's supposed to reach at the end of each dialysis. It is a complete figment of the imagination of the treating doctor, because it's not a dry weight and it's not estimated. It's just a figure. It is just a figure. Now, there are some people, of course, who have plans very similar to what I'm going to show in patients, which gets the patients down to a certain weight which they can call a dry weight. But that is absolutely the exception. So we're talking now about these so-called dry weights. So the first thing is to change all those dry weights and ignore them completely. If patients have a high blood pressure or have low blood pressure with cardiac failure, if they happen to be well controlled, fine, there's nothing, no worry about it. Many dry weights have not been updated for extended periods of time. Now, what I'm going to tell you now, this simple sentence describes what is necessary to achieve good results. It's to, first of all, have a standing order by a physician. Why a standing order? Because if there's no standing order in many dialysis units, there is a technician who does his or her best to take off the weight of patients who are complaining about the fact that when more than a certain amount is taken off, they're going to suffer cramps and hypertension. And I can say from a previous survey I did 30 or 40 years ago that if there's one thing that patients hate about dialysis, it's the feeling they get as their blood pressure drops and cramping. So there's a contract, not written contract, in many places between a technician working there for years and the patient as to how much fluid will be removed on that day, depending on how they feel. This is one of the obstacles to an adoption of what I'm saying. The standing order of a physician gives the technician a responsibility and a goal which can be achieved without a physician now getting involved again. And an RN will supervise this, one usually for 8, 9, 10 technicians the way things are now, but that RN can supervise and see this happens. So the idea is to decrease the post-dialysis weight by a very small amount, 200 grams to 300 grams every treatment. So in a week you get rid of close to 600 to 900 kilograms of weight. And you have to do this persistently. It takes 2.5 months and you have a patient who's close to normal tension and feels much better and doesn't have interdialytic problems. So if I sound like a kind of a evangelical missionary here, I'm convinced, I'm converted to this because it really does work. And if we were to do it, it would make a difference. Then maintain once we've reached a level, and as things change in medicine, if you had asked me 2 weeks ago whether this next statement is absolutely true, I would have said yes. Maintain the post-dialysis weight, the weight's left out there, at the same level once the pre-dialysis blood pressure has fallen to 130 or 140. But as you'll see as I get to the end of this, that may not be the best advice. We really have to be careful as we lower the blood pressure, even though the patient feels better, because it may not be completely right to keep lowering the blood pressure. There's a range of normal also for people who are on dialysis. Use an ultrafiltration method, and I'm sure most of you do this, which removes more fluid quickly during the first half of the treatment than in the second half, like a ratio of 2 to 1. For obvious reasons. The blood volume is lower, you go more slowly, but the total amount removed is the same. And if you have these machines that can lower the body temperature, lower it to a set amount. If you don't have machines, lower the dialysate temperature just generally. This has been shown to be very useful in studies by McIntyre, who shows that cerebral damage is reduced by just lowering the dialysis temperature. McIntyre. Very important to reduce the doses of hypertensive drugs, because Once this starts to work, the effective volume reduction, patients' blood pressures drop. And that again is causing the thing they don't want to see, because now it's because of the drugs. So they have to be reduced. And the ones to be reduced first are generally the calcium channel blockers and any alpha blockers. ACE inhibitors are probably very valuable, and certainly so are beta blockers. There's good evidence that both these drugs prolong life, and in this kind of situation, it's probably a good idea to use them in small doses. And one of the important issues is not to have drugs that are dialyzed. You have to have drugs that are not dialyzed, because if they're dialyzed, you lose the effect during the time when they may be needed the most, especially in regard to ACE inhibitors. So that's the recipe, and it's one that might be worth your attention and its practical application. Now some other points. The epidemiology of systolic blood pressure. Low blood pressure is a bad indicator of future mortality, as a good indicator of future mortality. In other words, the lower the blood pressure, the worse this response is. So we can't be confused about blood pressure being good in a dialysis patient. It almost always means that there's cardiac damage. Now I want to show you just this point which alludes to what I said a few moments ago about blood pressure change. This is an examination during treatment of a patient, and these three columns from top to top, these boxes from top to top, the first one is weight change and total body water change, and the second, I just must make quite sure I'm seeing it right. The blue marks here are the drop in blood pressure, and the red are the drops in cardiac output. And here, this is the most important thing to show you. These blue changes, these are individual treatments, there are 4 of them, and you see that in each case, the peripheral resistance rose sharply. Now, you have a situation then where you're dropping the blood pressure, things look good, but the cardiac output's dropped a little, but the peripheral resistance has gone up markedly. If this is a pattern that's very common, you see what it means. It means actually you may not have done the patient as much good as you thought, because having peripheral resistance that high, there's more work for the heart, but also there's more constriction, vasoconstriction of organs. So this kind of approach of trying to find out what happens during dialysis is probably a very good one. I'm not going to spend any time on this because of time. Just to say in the future, I believe one of the ways in which dialysis will eventually go is on this model that's already in use for getting rid of Ebola virus and hepatitis C and hepatitis B. It is something that looks like a dialyzer. It has very large pores. It allows plasmapheresis. So in the dialysate side, it's not dialysate, it's lectins which take up viruses. Now this could be, in another variant of this, larger, this could be plasma, which then has the uremic toxins removed from it, independent of their size and independent of their binding as a result of competitive substances being added. I think this will be something in the future that will change dialysis. Maybe wrong. And it's already in operation for the removal of viruses and exosomes, by the way, also. The wearable artificial kidney, I think, may have a time, but I can't think it's the future. I'm sure stem cells are more likely. So I want to now go straight on to the next topic and start with this quotation from Albert Einstein. We cannot solve our problems with the same thinking we used when we created them. And what I'm talking about is a new technique, which, as I said at the beginning, not in use in the United States, and that's hemodiafiltration. Now, basically, hemodiafiltration, I'm not going to give you the basics of it, but the idea is that instead of the only convective flow being what you remove by ultrafiltration, you infuse what is actually pure dialysate into the patient, something like 10 times as much as you would normally take out, and you remove that approximately 20 liters containing whatever is present in the bloodstream that is harmful. And that hemodiafiltration has been an invention for many, many years, and I don't want to talk about that. And you know some side effects of conventional hemodialysis, which I don't have to go into. All the things I've mentioned so far, the hypertension, the hypotension, the cardiac stunning, the stroke, all these things that we see. This is just an introduction. We know that KT/OV is important, but there are a lot of patients who need more total clearance, not of urea. That we do easily and well, and we've been doing that for years, but a total KT/OV for larger substances that are removed very poorly, that we do very poorly. And we need to change that as well. So, one of the first things that was shown, and it's a long time ago really, that you remove more middle molecules with hemodiafiltration. You see the difference isn't that great, but as you see a little later, the amount of ultrafiltrate, or the amount of removal by the hemodiafiltration was not very much either. So there was this hint that more middle molecules could be removed. Now that's very good, up to a point, because so many of the important uremic toxins are bound to protein, and there's just a small fraction that's free. Now those are dialyzed away, and then if there's time, the bound uremic toxin now becomes free, and that can be removed again. It requires a long time to do that to have an effect. Or if you have a very much more permeable membrane, then you can remove these larger toxins. But there's a limit to how much you can go without taking off albumin, and that would be a serious problem, so that can't be done. So, over an evolution of many years, the technique of hemodiafiltration has spread throughout the world, except in the United States. And the idea of putting dialysate into the solution in those volumes, those large volumes, is an obviously difficult one unless there's bacteriological and endotoxin purity, which has now been established. It's now perfectly safe to infuse 20 liters into someone and not have any problem. And it's an important issue because that was a limiting factor in many places. Now it's possible to have what is really ultra-pure water without any detectable endotoxin. In other words, less than 0.03 endotoxin units. I won't do that one. So the idea is then that convective therapies could reduce intradialytic symptomatic hypotension. And a lot of work went into that with several controlled, excellently designed, randomized controlled trials. And they showed this. Not a huge problem really, but clearly one that is very important for patients. And maybe it's not really clear why. It might be the removal of substances that are vasodilatory, or more likely it just cooled the patient down. When you put 20 liters in of a solution that's not at body temperature, that will cause some degree of vasoconstriction. That wasn't the main issue. It was good. It was a nice thing to have. Then it was noticed that a whole list of biomarkers are reduced, specifically inflammatory biomarkers are reduced in hemodiafiltration patients. So this was further confirmation that despite the limitations of the pore size, there was still an ability to remove these markers. Then DOPS introduced the general idea of a dose of convection. In other words, a small dose is a small volume removed and a large dose is a large volume removed. And here's the comparisons between low flux HD, high flux, low efficiency hemodiafiltration, and high efficiency. And efficiency has a question of volume of liters that are given into the patient. I mean, a very simple concept, but there seems to be a substantial difference when you go from about 15 liters upwards, as you'll see in a few moments. So there were several trials, as I said. So there was the Dutch trial, there was the Turkish trial, there was the Catalonian trial, and now there's a French trial, open label, randomized control trial, which compares high flux hemodialysis with hemodiafiltration. And the results of that will be some time still. Now, just very briefly, to show what we know. We don't need to know too much time for that. So here we have the result of the contrast, the Dutch trial, and you see there's no difference in survival. Very disappointing, because there were claims in non-randomized trials that there were big differences in survival. However, the mean volume that was achieved was very variable in different dialysis centers. It ranged from around 15 on average to something like 25, with a small standard deviation, 25 being sort of as much as you can get out of a 4-hour dialysis. The risk of death in these studies decreased with convective volume increase in that study. So that study that showed no difference in survival in a subset analysis, which of course is not statistically a valid analysis, nevertheless gave a hint that in that study there was actually a better survival. Survival did increase, the higher the mortality from left to right. So the Turkish study was now another study done virtually the same way with, again, the same idea of different volumes. And here you see the overall survival, nothing. The cardiovascular survival, nothing in the Turkish study. There was a lot of disappointment about this. However, when you stratify by the volume, you see that overall survival was significantly greater with volumes of more than 17 liters, as was cardiovascular survival, being the major contributor to the overall survival was cardiovascular survival. So this gave rise to a great deal of interest. It was not part of the study, it was again a subset analysis. So finally, the Spanish study came out, which was different in this sense that they had a range of volumes substantially greater than the other two studies that I've mentioned to you. Some up to 22, 23 liters on average. And there was a survival benefit for hemodiafiltration versus hemodialysis when you looked at the whole range of volumes that were included. So, you have to take it at face value. There is absolutely a significant improvement from this. And if you look at the death rate, you'll see that it's markedly reduced in terms of events per 100 patient years. You see them emphasized in the yellow, and stroke and infections. All these were improved as the result of this very high volume hemodiafiltration. I was very skeptical of this. Not that my opinion counts, because it didn't make sense to me what was actually happening. My preconceived idea was that what we were removing wasn't enough. But it's now pretty clear from a paper that's published the day before yesterday online in KI, working on the study of the Spanish study, sent to me kindly by Bernard Cano, because I told him I was talking about this, and this shows very clearly that with higher convection, the amount of beta-2 microglobulin is markedly increased with increased volume. So beta-2 microglobulin being a large molecular weight compound. Similarly, there is a effect of relationship between survival rate and CRP, and CRP is very well removed, so you have survival improving with more removal of CRP, an inflammatory marker which may have a role in inflammation as well. But the important thing is that evidence is now being shown that you actually are removing significant amounts of middle molecules, and presumably that's the reason why the survival is now better with hemodiafiltration. And this shows the relative survival of patients as the volume increases. And you can see there's really a very strong relationship between increased volume and increased survival. So, looking at it objectively, it looks to me that hemodiafiltration employed in this manner is going to be a significant addition to our armamentarium in dealing with dialysis. Not everyone can take these large volumes, certainly not. The accesses won't allow it, and there are some patients who may not react very well to the entrance and exit of large volumes. But for the majority of patients, this might turn out to be useful. It is used, as I said, throughout Europe. One has to know the literature. So I have take-home measures that online hemodiafiltration offers a superior treatment. It's not a generic term. It's the convective dose that matters. and it's used frequently everywhere in the world, so except in this country. And it does remove a wide range of uremic toxins. And then microbiological safety has been proven, and the recent trials tend to support the superiority of HDF compared to the standard high-flux dialysis. But we need further clinical trials to actually see what's the best dose for the individual patient. And also there's a question always with us of cost effectiveness. So we need to know the literature. And in saying I need to know the literature, I want to read you this cartoon. So here you have two gunmen looking at each other. The one says, "Don't move while fully full of lead." The other one says, "Ha, I happen to know that the lead in bullets is in the metallic form. This chemical form of lead has an intrinsically low bioavailability and toxicity and cannot harm me." The other one says, "Yes, but Earp et al., 1882, have recently reported that the gunpowder-assisted acceleration of this form of lead to 1,000 feet per second substantially enhances its ability to penetrate biological membranes, effectively making it a whole lot more toxic." And he says, "I don't believe I read that paper." So, okay. On that note, I thank you for your attention, and I hope that those of you interested will speak to me about this approach.
Thank you, Dr. Levine. I know we are running late, and I know we had excellent speakers. So I want to ask the audience, do you want to take a break and maybe the questions later on, or would you like the speakers to come up and I'll take a vote? Do you want a break? So the speakers, I guess what can be done in this situation is that if people have questions, they can sort of send it to me, and I can email them to the speakers, and they can respond back to the audience who had the questions. So let's take a break if it's okay. Thank you, Dr. Levine, for the excellent talk. Thank you, Dr. Sumner. Thank you, Dr. Roy. And I hope everybody has more questions they can email. Thank you. So we will meet back in about 10 minutes or so, 10, 15 minutes.